So how did we deal with the issues of dissemination and utility in the real world with CBT? So one of the things that we did was essentially go back to stage one and see if we could use technology as a strategy to improve the ability of high quality CBT to be delivered in the real world of substance abuse treatment, where there are all kinds of challenges. So why did we do this? As we talked about earlier, effective implementation of CBT and other evidence-based therapies is really very rare in clinical practice. There's not any sort of structure to assess or monitor delivery of treatments or performance or outcomes. The other problem is that we know that only a fraction, maybe 10% of those with substance-related problems actually access treatment, so we have a reach problem. And we didn't conceive of using technology to replace clinicians, rather just to extend them. So the clinician could focus on connecting with the patient, assessing what they needed, doing all kinds of clinical management, having a strong relationship, and they could essentially reinforce or provide CBT through this use of additional technology. And we also recognize there's a lot of things that computers do really, really well. They can teach relatively well, as we're learning through this course. We also used multimedia features to see if we could deliver and to train and teach and practice CBT skills more effectively. What also was really nice from the perspective of a psychotherapy researcher, by using technology to make a computer-based version of CBT delivered in modules, it became a great way of being able to study CBT much more systematically and much more effectively. And again, in the real world, we don't have standardized delivery, but a computer never gets tired of doing CBT, so we get a nice standardized, high-quality version of CBT. So a little bit about the core principles and how we approached this from a psychotherapy development point of view. One thing is that we knew we were dealing with substance users with relatively short attention spans, not a whole lot of computer skills, and probably not a lot of interest in reading a lot of stuff on a website. So we tried to make it as engaging as possible, really capturing their attentions, retaining them in treatment, entertaining while teaching. What we knew we wanted to do, since we didn't have the non-specific elements of alliance and so forth, is we wanted to build a skills training machine. How can we use this technology to deliver the most potent form of CBT skills training that we possibly could? And we did this by saying it's just a skills training machine. We're just going to focus on these 6 or 7 core cognitive behavioral ideas and try to teach them in a generalized way. So an example would be, yes, we're teaching you these strategies for urge surfing and coping with cravings for alcohol or drugs. But also think about it. These are also strategies that you can use to deal with strong affects, feeling really good or really bad without resorting to substance use and so forth. We also wanted to have this be a durable approach, like CBT sleeper effect. So we really focused on having the participants practice these skills. So the thing is full of homework, quizzes, opportunity to sort of do these skills both within the computer session and outside. And modeling. And I think this is what really made it go for us. We wanted to show people use these skills in realistic settings. So we basically produced a bunch of movies, very realistic movies. They're like soap operas, where you see the character actually use the skill that we just taught in a really realistic session with pushback and pressure and emotions and all kinds of things. And I think it's a good way to learn. So I'll just go through this relatively quickly. EBT is 7 modules. It covers those core topics that are shown here: functional analysis, coping with craving, risk reduction, and so forth. If you're interested in seeing it, there's a 5-minute demo at the website cbtforcbt.com. It collects no protected health information. It's fully secure. You don't really need reading skills. It works on all kinds of platforms, and there's ways of tracking whether people do their homework and answer the questions correctly and so forth. This is just a screenshot from the alcohol version. We have an alcohol version, drugs and alcohol version, and several others coming out. And again, once we built it, it was important to show that this web-based program actually carried the characteristics of CBT. So we did a series of randomized clinical trials trying to understand, was it effective as an add-on to treatment and alone? Did it teach the skills in an effective way? Did it carry important characteristics of CBT like the sleeper effect and so on. So from our first CBT trial, this is just this overall outcome. We just added CBT to standard treatment as usual, which was weekly groups and individual setting at a community-based program. And all the participants who were assigned to CBT for CBT did was like work with the program up in an office once or twice a week. And we got roughly a 20% difference in terms of drug-positive urine outcomes by the end of the treatment. So that's pretty good for a little website. The other thing that we did was actually use our blinded role play assessment to see if those assigned to CBT actually learned some of the skills. By and large, as you see here, people assigned to TAU did not show much variance in their skills from baseline to the end of treatment and through follow-up. But when we actually brought the CBT participants back for a 6-month follow-up, their skill level actually increased, even though they didn't have access to the program during this time. So it at least suggests that we taught them some key generalizable skills. We also got a very, very nice sleeper effect with this particular study. So now that we've done several other trials, this next one took place in a methadone maintenance program with methadone-maintained individuals also using cocaine. And as you see here, we get the same kind of 20 to 30% effect size over standard, good enough methadone treatment. And again, we had our nice sleeper effect and taught the skills. Our version for alcohol, we just finished an outpatient trial there. This one was comparing standard alcohol treatment, again, in groups and individuals over about 8 weeks, to CBT for CBT delivered pretty much alone with just minimal clinical monitoring or CBT on top of treatment as usual. Both forms of CBT for CBT clearly retained more patients and resulted in clinically significant drinking outcomes through the 8-week approach. And again, we've done, so this is a great strategy for dissemination. This is a screenshot from our most recent version, which is a culturally adapted version of CBT done entirely in Spanish as a telenovela. Completion rates for this thing are high because everybody wants to see what happens to the characters. So again, by entertaining and drawing them in, we're delivering CBT to a population of substance users that's often ignored by the treatment system. So this is very exciting. So again, by attending to the stage model, I think we found a strategy for actually getting CBT to the clinical community. And now I think we are at stage 4 or 5. CBT for CBT has been picked up by a variety of early adopters. We just see who wants to come and work with us, so it's often done in rural settings. Interestingly enough, with no modification, the Native American and First Nation communities have embraced it, sought it out, and think it's terrific. And we've been implementing CBT for CBT in primary care. So in short, the stage model and adhering to it and thinking about how we can bring these evidence-based therapies into the real world has been very satisfying, both in terms of making the treatment of substance users better than when we began, but also we have this wonderful standardized treatment where we can study CBT more effectively and hopefully make it better and better. Thanks.